Let me tell you how these immune complexes lead to formation of inflammatory reaction, right? I will explain it to you that how inflammation occurs. Let's suppose here is this immune complex deposited, right? Here is this, what is this? ATG, right? And complex is not one, they are multiple. Here immune complexes are deposited. Now at this part of the vessel, there should be vasculitis, inflammation of the vessel. How it occurs? One way is very simple to understand, that FC portion of these, what is this? These antibodies may activate neutrophil, right? And neutrophil release, yes, what neutrophil will release? Or they activate neutrophil, or they activate, yes, macrophages, and they will release oxygen derived, yes, free radicals, which will damage the local tissue and produce inflammation and necrosis. Number two, they will release lysosomal enzymes, right, in an attempt to eat up these complexes, and that will also do the inflammatory reaction, right? Along with that, and some of these FC portion, look here, in some of these FC portion, cell did not bind but complement bind. So what really happened, that let's suppose complement C1, 4, 2, C3, C3b will be binding there, 3b, 3a will be removed, 4a will be removed, then 5b is there and 5a is removed, right, b, and 6, 7, 8 and 9. So what is this? C5b to 6, 7, 8 and 9, this is membrane attack complex, membrane attack complex. So it means at the site of immune complex deposition, complements are stimulated, and this complement activation may lead to formation of lot of membrane attack complex. These membrane attack complex will damage the local tissue. If it is vessel wall, they will damage the endothelial cell, they will damage the, what is this, endothelial cells, they will damage the underlying smooth muscle and fibroblast in the media, so there will be further inflammatory damage. Plus this C3A and C5A, right, C3A and C5A, right, these two, C3A plus C5A, these two complement fragments have a capability to activate the, what is this cell, mast cell. Mast cell have receptors for these two things, and mast cell release their product like histamine, which increases the permeability, and more complexes come deeper, right, and proteolytic enzyme which produces inflammation. And then mast cell also release prostaglandins, they release leukotrienes, and they release, you already know, that neutrophilic chemotactic factors and eosinophilic chemotactic factors. So more inflammatory cells will be coming there, and more inflammatory response will be there. At the top, C5A has one more function. What is that function? It acts as chemotactic agent for the neutrophils. So lot of neutrophils will rush towards that site. Lot of neutrophils will rush towards that site of reaction. Is that right? So C5A is working as a very powerful chemotactic agent. So it means complement activation damages the local tissue by membrane attack complex, plus it calls more neutrophil, plus it activates the mast cell to amplify the further inflammation. Am I clear? Meanwhile, when endothelial cells are damaged here, look, these endothelial cells are damaged. Endothelial cells which are damaged, they lose their anticoagulant and antithrombotic properties. Normally, healthy endothelium is antithrombotic. It does not allow the platelet to stick. And healthy endothelium does not allow the coagulation system to be activated. But when endothelial cells are injured, right, they allow the platelets to stick there. So what really happens? The platelets start sticking to this area. And when platelets start sticking to this area, microthrombi are formed. And if microthrombi are formed, it will clog the smaller size vessels. And at the top, there may be Hageman factor activation. Immune complexes can directly activate the Hageman factors as well, right? So that may lead to, you can say, microthrombi formation, microthrombi formation, and that will lead to ischemic injury. Ischemic injury. That will lead to ischemic injury. So how much problem is there? That in this vessel area there is severe inflammation and necrosis of the local tissue. And in this media, if you really look, if this was a vessel wall, let's suppose if I make a this is endothelial lining of a vessel wall, right? This is endothelial lining. Here is media, smooth muscled, right? And here is, yes, adventitia. This is advent. Is that right? This was the vessel wall. Now reactions occurred here that at this point antigen antibody complex is deposited and they activated the neutrophil and mast cell and went into deeper. And here actually all these reaction is, look, all these reactions are occurring at this point. So immune complexes have come deeper. With that, complement have also come deeper. And because endothelial cells are you can say activated and interendothelial gaps are formed, even fibrinogen from the blood as fibrin has come into deeper. So in this area, you will find that there is smuggy eosinophilic deposits. There is in this vessel wall, you will find, and you will not find in this area any structural detail. Can you see the normal structural detail of vessel wall here? No. In this area, you cannot find the normal structural detail of the vessel wall. So what is this? That this area will be as if there's a lot of fibrinide material deposited. But what this material is? What is this material? The material which is deposited here is antigen plus antibody complex. They are deposited there, plus complements are deposited there, plus fibrin is deposited there, plus local necrotic tissue is deposited there, necrotic cells. Now all these things, antigen antibody complexes and complements and fibrin coming from the blood and local necrotic cells and dead cells, all of them stain in eosinophilic color and without any structural detail. Is that right? So this point is called fibrinoid necrosis. What is this point called? Yes, fibrinoid necrosis. Fibrinoid necrosis is the hallmark of type 3 hypersensitivity reaction. Fibrinoid necrosis in the vascular media. So there is immune. Now let's define what is type 3 hypersensitivity reaction. In type 3 hypersensitivity reaction, immune complex are deposited, especially in systemic type 3 hypersensitivity reaction, immune complex are deposited within the vessel walls and many other tissues and producing intense inflammation characterized by fibrinoid necrotic lesions. So some people simply call it, there is fibrinoid necrotic vasculitic lesions. The hallmark of type 3 hypersensitivity reaction is fibrinoid necrotic vasculitic lesions. What are these lesions? If you study these lesions by immunochemical ways, right, you will find that in fibrinoid necrotic area, you have local necrotic cells, you have antigen antibody complexes, of course immune complexes, you have complements, and you are having fibrin, and maybe around this area you have a lot of neutrophils also, right. So whenever you find that in a patient body at multiple small vessels are having fibrinoid necrosis, multiple small vessels have fibrinoid necrosis, you must think of type 3 hypersensitivity reaction. Is that right? Now, we were talking about pathogenesis up to now. We did not talk about the clinical features in this patient, right? We will talk about them after the break. Let's suppose this is our patient and we see what really happens to this patient. He is happy. The good news is that he is recovering from aplastic anemia, which is more deadly. But very soon he will be little sad because now serum sickness type situation starts. What will happen to this patient? Number one, all over the body, as in multiple areas, lot of immune complexes are deposited, lot of white cells are stimulated, so lot of cytokines are produced, and these cytokines will go to the, especially interleukin 1 and tumor necrotic factor, they will go to the hypothalamus and they will produce, what is this? Fever. So after the injections of ATGs, about, you can say 2 weeks, 10 days to 15 days, patient will start fever, and with the fever, patient will develop other features of constitutional features of highly circulating cytokines. As I told you, in multiple areas of the body, inflammation is there, inflammatory cells are producing cytokines. The cytokines alter the hypothalamic function. Due to that reason, patient develop fever, patient develop fatigability, patient develop lassitude, right? And with these constitutional features, patient will develop generalized lymphadenopathy. Lymph nodes start enlarging. Generalized lymphadenopathy, that because multiple lymph nodes in the body start enlarging. Multiple lymph nodes in the body start enlarging. Is that right? So there is generalized lymphadenopathy. Now along with that, the further clinical features will develop according to the which tissues are taking up the deposits. Many small blood vessels take up the deposits and develop inflammatory lesions. So patient develop multiple vasculitic lesions, and these vasculitic lesions will be evident by rashes on the skin, because the vessels under the skin, when they will undergo vasculitic inflammation, antigen antibody deposition, complement activation, neutrophil arrival and damage, so all this will produce skin rashes. That will produce skin rashes, right? There will be skin rashes. With that, what else will be there? That there will be similar antigen antibody deposition in the glomeruli, and within the glomeruli there will be activation of the complements, and there will be neutrophil infiltration, and that will damage the glomerular structure. So glomerular basement membrane will be damaged, and when glomerular basement membrane will be damaged, you can understand that what will happen, that will produce glomerulonephritis, which will be clinically evident by proteinuria and proteinuria and hematuria, plus patient may develop flank pains. Is that right? So glomerulonephritis may be there, and there may be skin rashes, there may be generalized lymphadenopathy. With that, maybe pericardial sac or pleural, you can say pleura, may become inflamed, right? And that may produce, because antigen, you can say antigen antibody complexes or immune complexes love to deposit in the pericardial cavities, pericardial lining or pleural lining. So patient may develop chest pain due to pericarditis, or patient may develop chest pain due to pleuritis. So patient develop chest pain, patient develop glomerulonephritis. Along with that, I don't know why, but they say that these immune complexes love to deposit, they have special affinity for the synovial membrane in the joints. So when the synovial membranes in the joints, they will be, you can say, developing immune complexes. Patient may develop, what are these? Polyarthritis. So patient may develop polyarthritis, right? Patient may develop polyarthritis. So hematuria with proteinuria, polyarthritis, skin rashes, generalized lymphadenopathy with fatigability, and you can say fever. All this is hallmark of the serum sickness or generalized type 3 hypersensitivity reaction, or we call it generalized type 3 hypersensitivity reaction, right? After this thing, this was a typical model of type 3 hypersensitivity reaction. Usually what happen that in case of serum sickness or when foreign serum has been introduced, right, usually after few days or weeks situation will settle down, as eventually most of the antigens will be removed by and complexes will be removed by at last by the nuclear mononuclear phagocytic system. But in some conditions there is chronic antigenemia. For example, if you develop similar reaction towards your own antigens, right, then there is chronic antigenemia, and if there is chronic antigenemia, then disease will become prolonged. I will give you some few more classical examples of type 3 hypersensitivity. One example is SLE. Now in SLE you must remember, autoantibodies react with the RBCs or platelets or neutrophils. That is type 2 reaction. Actually in SLE type 2 reaction occur as well as type 3 reactions occur. SLE is an autoimmune disease in which the multiple autoimmunological reactions are going on in the body. Is that right? So there are type 2 reactions. The example is that in SLE antibodies react against RBCs or platelets, membrane, or with the neutrophil. That is type 2 reaction, right? But in SLE there is type 3 reaction also, because when cells are damaged, their DNA is released in the blood or their nucleoproteins are released in the blood, and patient's DNA or nucleoproteins are taken by the patient's immune system as foreign. Then patient make antibodies against his own DNA. So in the patient's blood, DNA is circulating and anti-DNA antibodies are also circulating. So DNA and anti-DNA antibodies together make immune complexes. Is that right? So this is one example is SLE, which is an example of there is endogenous antigens leading to chronic antigenemia, and that is leading to chronic type 3 hypersensitivity reaction. Another classical example is rheumatoid arthritis. Rheumatoid arthritis. In rheumatoid arthritis, what really happens? In rheumatoid arthritis, patient has developed IgM against his own IgG. Patient has developed IgM against his own IgG. It means patient's own IgG is acting as antigens and he is developing IgM against his own IgG. Is that right? This IgM is called rheumatoid factor. What is it called? Rheumatoid factors. So this is another example where patient has developed IgM against his own IgG, and IgG is acting as an antigen and IgM is acting as antibody, and antigen-antibody complexes are found in circulation and deposited into multiple tissues in case of rheumatoid arthritis. Then another example is polyarthritis nodosa. That is polyarthritis nodosa. In polyarthritis nodosa, the circulating antigen is hepatitis B surface antigen. In these patients, hepatitis B surface antigen is chronically, you can say, circulating in the blood, and against hepatitis B antigens, antibodies are formed and antigen-antibody complexes start depositing into multiple blood vessel walls and develop necrotic lesions in the blood vessels that lead to weakness of the arterial walls, and their arterioles or arteries become inflamed, and then they make aneurysmal dilatation in multiple arteries. So we call it polyarthritis nodosa. Another example is you can say post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis. There are some people after streptococcal infection, some of the streptococcal antigens exist in circulation for longer time, and anti-streptococcal antibodies react with the streptococcal antigens, and immune complexes are formed which especially love to deposit in glomeruli. Or in some of these patients, some streptococcal antigens are first planted into glomerular-based membrane, later antibodies reach there and make in situ immune complexes which activate their complements and attract the neutrophil, damage the endothelium of the glomerular capillaries, produce microthrombi and severe damage. Right? Then there can be another example of this is a reactive arthritis. Reactive arthritis. For example, some people who suffer with infection of Yersinia in the GIT. Yersinia antigens circulate in the blood for a long time and you develop anti-Yersinia antibodies. Antigens and antibodies deposit in joints and patient develop reactive arthritis to GIT infection. Originally there was GIT infection which led to acute arthritis, right? Why? Because immune complexes were formed and deposited into joints. Is that right? One more example is, if you love, is serum sickness, and I think that is what we have already discussed. Again, it's worth repeating that these days most common cause of system type 3 hypersensitivity reactions are drugs. Having said all of this, now few words about the localized type 3 hypersensitivity reaction. You remember localized type 3 hypersensitivity reaction was called Arthus reaction. Localized type 3 hypersensitivity reaction is called Arthus reaction. Now we will talk about Arthus reaction. One of the classical example of Arthus reaction is farmer's lung. One of the classical example of Arthus reaction is farmer's lung. You know what is farmer's lung? Some people, right, who are working in the you can say farms, right, and there's a lot of dust and there are thermophilic actinomycetes. Thermophilic Arthus reaction we are going to talk about. Arthus reaction, which is localized type 3 hypersensitivity reaction. Is that right? One example is farmer's lung. In farmer's lung, the special type of pneumonitis, let me tell you what really happens, that in their lungs, first fungi come. These are thermophilic actinomycetes. Now these fungi, when they are coming to their lungs, some of these people develop antibodies against these fungi. Is that right? Now when they get re-exposure to the same antigen, as these antigens are coming into lung, right, what really happens, from blood side antibodies come, and these antigen antibody react with each other. These antigens with the antibodies react with each other and they activate the complements and neutrophils and produce typical type 3 hypersensitivity reaction lesions, but within the only pulmonary circulation. Is that right? So patient will develop pneumonitis. Another example of Arthus reaction is when you give injection of some substance against which patient has already made. For example, here is the antigen patient has already made. These are the antigens which are coming from injection, and let's suppose this is the blood vessel of the patient. Now what really happens? As antigen is coming, you are injecting the antigen, it is coming, the preformed antibodies already in the circulation. Due to previous exposures, the preformed antibodies present in circulation. As antigens come here, antibodies start reacting. And in this way, antigen-antibody complexes will form, and remaining storage, you know, that when antigen-antibody complexes are formed, locally complements will be activated, neutrophil will come, local endothelial cell will be damaged, microthrombi will be formed, fibrinoid, necrotic, vasculitic lesions will be formed in the media. Is that right? This is called Arthus reaction in the skin right, within the skin. This type of reaction is sometimes done to check the allergy against a particular substance, right. When you inject a substance in the skin and patient has developed antibodies, IgG or IgM, circulating antibodies against that particular substance, then arthritis reaction will start occurring here. This will start making some redness and some edema in this area and eventually ulceration, right. This lesion will start appearing within few hours and it will reach at the peak around 10 to 12 hours. Is that right? But it does not develop immediately. Remember, if you inject a substance and within few minutes red area appear, this is type 1 hypersensitivity. Why? Because patient has developed IgE against that substance and mast cell degranulated. But if a reaction occur after many hours and reaches to the peak 8 to 10 hours, and if you do a histopathology, you will find there is fibrinoid necrosis of the local vessel walls, and there are a lot of immune complexes and complements and neutrophils and fibrin there. Of course, then it is type 3 hypersensitivity reaction, right? A skin testing is also done like Monto's test for type 4 hypersensitivity reaction, which we will discuss later. There it takes longer time for the reaction to appear in the skin. Is that right?